A very good morning and welcome to a session on a very important topic, which is PCOS. We are glad to have Dr. Preethi with us today to help us understand the topic and give us the vital informations we all need on this very important topic. The doctor will help us understand in brief, and if you have any questions, any doubt in between, you can drop in the comment sections. The doctor is here to answer your questions. Doctor, you have this thing.
Hello, good morning, everyone. I'm Dr. Preethi, consultant fertility specialist here in Apollo Fertility, Nagar. So today I'm going to discuss in detail about a common topic, which is one of the leading causes of infertility now, which is called the polycystic ovarian syndrome. So in simple terms, in Tamil language, we call it as neerkatti prachane. So first, I'm going to describe about normal ovulation, normal menstruation, what happens between the uterus, the ovaries, and the brain. How does a normal female ovulate? So first, you have to understand this, and only then you can understand what is happening in polycystic ovaries. So to understand about normal ovulation, you should understand that the ovary is connected to the brain by some hormones. The ovary can secrete some hormones which act like signals to the brain, and the brain signals the uterus. So it is like a triangle, the uterus, the ovary, and the brain. So they are all interconnected. So first, what happens is the ovaries they act like egg banks. So there are many eggs stored in both the ovaries. Many thousands and thousands of eggs are there in both the ovaries. So every month, what happens is about 8 to 10 eggs they come to the surface of ovary. The brain selects one among those eggs, which is the best. Only that egg will be able to outgrow all the other eggs, become a dominant follicle, and it breaks to release the female oocyte. So this oocyte joins with the sperm to form a baby. The broken egg, which has released the female oocyte, further secretes some hormones. So this hormones, it helps in the development of the uterine bed. So the meaning of this is the follicle which has broken and which has released the female oocyte, it is arranging the bed inside the uterus so that if the baby forms, so that if the oocyte is fertilized by the sperm and if the female falls pregnant, for the baby to come and get implanted inside the uterus, it needs a proper uterine bed. So the broken follicle develops the bed and it keeps the bed alive for 2 weeks. So if the pregnancy is formed in that cycle, the baby goes and attaches itself beautifully inside the uterine bed. If pregnancy doesn't happen, then the follicle which has broken and which is secreting the hormones, it also dies. So the whatever bed is formed inside the uterus, it breaks down and comes out as your regular periods. So this is what is happening in a normal ovulation and normal menstruation. For people who can't understand English, I wish to tell the same thing in Tamil now. That is, ஒரு மாசமும் கிட்டத்தட்ட 8ல இருந்து 10 முட்டைகள் அந்த முட்டைப்பையோடைய சர்ஃபேஸுக்கு வரும். அந்த பிரெயின் நம்மளோட ஹியூமன் பிரெயின் வந்து செலக்ட் பண்ணும் முட்டைப்பையில நிறைய ஆயிரக்கணக்கான முட்டைகள் இருக்கும். கிட்டத்தட்ட 8 to 10 எக்ஸை செலக்ட் பண்ணி சர்ஃபேஸுக்கு கொண்டு வரும் எவ்ரி மந்த். இந்த 8ல இருந்து 10 முட்டைகள்ல இருந்து ஒரு முட்டையை செலக்ட் பண்ணும். எந்த முட்டை அதிகமான ஹார்மோனை செக்ரீட் பண்ணுதோ அதுதான் செலக்ட் ஆகும். அதுதான் டாமினன்ட் ஃபாலிக்கல்னு சொல்லுவோம். அந்த டாமினன்ட் ஃபாலிக்கல் மட்டும் நல்லா பெருசாகி உடஞ்சு உள்ள இருக்கிற பெண் கரு வெளியில வரும். அந்த பெண் கரு ஆண் விந்தோட சேர்ந்து கருவா மாறும். உடஞ்சு போன அந்த ஃபாலிக்கல் அடுத்தது கர்ப்பப்பையை ரெடி பண்ணும். கர்ப்பப்பையோடைய உள்ஜவ்வை ரெடி பண்ணி கரு ஃபார்ம் ஆச்சுன்னா கருப்பை நல்லபடியா ஒட்டுறதுக்கு ஹெல்ப் பண்ணும். கரு ஃபார்ம் ஆகல அப்படின்னா 2 வாரம் கழிச்சு அது செத்து போகும், அந்த உடஞ்சு போன முட்டை. அப்போ உள்ள சேர்ந்திருக்கிற அழுக்கு பீரியட்ஸா வெளியில வரும். For people who cannot understand English, I wanted to tell this in Tamil. So this is what is happening in normal physiology, normal ovulation and normal menstruation. So next, what happens in polycystic ovaries? In polycystic ovaries, the first thing which happens is every month about 8 to 10 eggs alone doesn't come to the surface of the ovary. Because of some genetic issues, because of some environmental problems, because of some lifestyle issues, The problem here is about 20 to 25 eggs, they come to the surface of the ovary. So 20 to 25 eggs, they secrete some amount of hormones and they signal the brain. So what happens, the brain is not able to select one particular egg or one particular follicle and doesn't allow any follicle to grow properly to become a dominant follicle. So that is the most important pathological problem here. Instead of 8 to 10 eggs, so many eggs are getting recruited every month. They go to the surface of the ovary. All these eggs say secrete some amount of hormones. So these hormones, they cause some sort of hormonal imbalance in the body and they cause some sort of defective brain signaling. So the brain is not able to select one particular egg. So that is why dominant follicle is not formed, and that is why ovulation doesn't happen in polycystic ovaries. So that is why they have anovulation. That is the first and most important complaint in a polycystic patient. Second important complaint is irregular periods. So as I told you earlier, so the dominant follicle is supporting the uterine bed. The dominant follicle secretes some hormones for the uterine bed to develop properly. So once the dominant follicle dies, the uterine bed also dies and it gets shed as the periods. But here, since there is no dominant follicle selection, there is no source for the uterus to develop a proper uterine bed. அதாவது ஒரு முட்டையே செலக்ட் ஆகல அப்படின்றப்போ அந்த முட்டை வெடிச்சு அந்த முட்டையிலிருந்து வர ஹார்மோன்ஸ் தான் கர்ப்பப்பையுடைய உள்ஜவ்வை டெவலப் பண்ண ஹெல்ப் பண்ணும். ஸோ இங்க முட்டையே செலக்ட் ஆகல அப்படிங்கிறப்போ அந்த கர்ப்பப்பை உள்ஜவ்வு டெவலப் ஆகிறதுக்கு எந்த விதமான ஹார்மோன் சோர்ஸும் இல்லை. அதனால கர்ப்பப்பை உள்ஜவ்வு டெவலப் ஆகிறது இல்லை. இல்லைன்னாலும் அது டெவலப் ஆனாலும் அது சரியா வெளியே வர்றதுக்கான ஹார்மோன் சிக்னலிங் இல்லை. That is why these people, they have irregular periods. This is the second commonest complaint in patients with polycystic ovaries. Third complaint is hyperandrogenism. அதாவது அதிகமான ஆண் ஹார்மோன் செக்ரீஷன், ஆண் சுரபிகள் செக்ரீஷன் நம்ம பாடியில இருக்கும். மேல் ஹார்மோன் செக்ரீஷன் இஸ் மோர், which can manifest as acne, hirsutism, obesity, baldness, hypotrophied or hypertrophied male pattern breast developments, abnormal hair development all over the body. All these things can happen. அதாவது நம்ம முகத்துல பரு இல்ல முகத்துல முடி முளைக்கிறது, உடம்புல எல்லா இடத்துலயும் ஒரு மேலுக்கு இருக்கிற மாதிரி ஹேர் டிஸ்ட்ரிபியூஷன், குண்டாகிறது, தொப்பை போடுறது, ஹேர் ஃபால் நிறைய இருக்கிறது, இது எல்லாமே வர்றதுக்கான காரணம் ஹைப்பர் ஆண்ட்ரஜனிசம். ஏன் இந்த ஹைப்பர் ஆண்ட்ரஜனிசம் பாலிசிஸ்டிக் பேஷண்ட்ஸுக்கு நடக்குது அப்படின்னா, நான் சொன்ன மாதிரி கிட்டத்தட்ட 20ல இருந்து 25 முட்டைகள் மேல சர்ஃபேஸுக்கு வந்துடும் இந்த பாலிசிஸ்டிக் பேஷண்ட்ஸுக்கு. இந்த எல்லா முட்டைகளும் ஹார்மோன்ஸை செக்ரேட் பண்ணி பிரெயினுக்கு சிக்னல் கொடுத்துக்கிட்டு இருக்கும். அப்போ இந்த ஹார்மோன்ஸ்ல மேல் பார்ட்டும் இருக்கு, ஃபீமேல் பார்ட்டும் இருக்கு. எக்ஸஸான ஹார்மோன் செக்ரீஷன் நடக்கும்போது ஃபீமேல் பார்ட்டை விட மேல் பார்ட் ஓவர்டேக் பண்ண ஆரம்பிச்சிடும். So that is why hyperandrogenism happens. When the hormone secretion happens from all the 20 to 25 follicles from each ovary, so there is excessive amount of hormone secretion which leads to hyperandrogenism. ஹைப்பர்ஆண்ட்ரோஜனிசம்னா நான் சொன்ன மாதிரி இந்த ஒபிசிட்டி தட் கேன் ஹேப்பன். இந்த ஒபிசிட்டினால என்ன ஆகும்னு பார்த்தீங்கன்னா, பிரெயின்ல இருந்து ஓவரிஸ்கோ யூட்ரஸ்கோ வர சிக்னல் இன்னும் ஹேம்பர் ஆகும். ஸோ இது அப்படியே ஒரு சைக்கிள் மாதிரி கண்டினியூ ஆகும். திஸ் ஹேப்பன்ஸ் லைக் a cycle. So the excessive hormones further increases the obesity. Obesity further disturbs the brain signaling to the uterus and to the ovary. So this cycle, this hyperandrogenism, obesity, anovulation, and irregular periods, this entire pathology, we call it as polycystic ovarian syndrome. இதுதான் நடக்குது இங்க பாலிசிஸ்டிக் ஓவரிஸ்ல. ஸோ இப்போ அடுத்தது, இந்த பாலிசிஸ்டிக் ஓவரிஸ்னால என்னெல்லாம் காம்ப்ளிகேஷன்ஸ் வரலாம், இந்த பாலிசிஸ்டிக் ஓவரிஸ் எத்தனை வகைப்பட்டது, ஹவு மெனி டைப்ஸ் ஆஃப் பாலிசிஸ்டிக் ஓவரிஸ் சிண்ட்ரோம்ஸ் வி ஹேவ். இப்போ ஒரு 10 பேர்ல 5 பேருக்கு நம்ம ஸ்கேன் பண்றோம்னா அவங்களுக்கு பாலிசிஸ்டிக் ஓவரிஸ் மாதிரி தான் தெரியும். ஆனா எல்லாருக்கும் காம்ப்ளிகேஷன்ஸ் வர்றதில்ல. நாட் ஆல் women with polycystic ovaries they have problems in conceiving, they have problems in periods. No, not all patients they have problems. It is only a percentage of patients who has difficulty in conceiving, difficulty in getting their regular periods, difficulty in maintaining a proper BMI, and difficulty in having all these hyperandrogenic features. It is only a proportion of the females who gets affected by this polycystic. So what are the different types of polycystic we have, and why do some women have problems and some women they don't have problems? Why is that? So first thing is, in a polycystic ovarian syndrome, the first type is women who have all the symptoms, that is anovulation, irregular periods, hyperandrogenism. All these three features will be present in the woman. The second type is a second, third, and fourth type. All the three types, only two out of the three will be manifested. So that is, some women they can ovulate very randomly. They ovulate. The brain suddenly sends one signal so that one follicle from the whole lot they get selected and suddenly they break and they release the egg. So random ovulation can happen. Whereas the women will have irregular periods, the women will have hyperandrogenism, all the other features will be there. Similarly, the other two types are, the women can get periods regularly. Regularly in the sense not every month, or once in every 2 months, or once in every 3 months. She will have her periods, but she will not ovulate properly, and she will also have these hyperandrogenic features. The third type is, the women may not have hyperandrogenic features. The excessive androgen component doesn't overtake, but still she has hormone imbalance which causes irregular periods, and she also has a defective ovulation part. The brain is not able to select one particular dominant follicle, so ovulation does not happen. So these are the different types of polycystic ovaries. In clinical practice, we see patients from all categories. The usual most common complaint is patients with all three complications, that is anovulation, irregular periods, and hyperandrogenism. Very rarely it is the patients who ovulate but they have irregular periods and hyperandrogenism. The next thing is hyperandrogenism alone is absent, but the other two features are present. So this is the incidence. Next is, what are all the complications of this polycystic ovaries? So what all you can expect in a patient with these complaints. So as expected, the patient is not able to ovulate, or the patient is not able to produce one healthy egg. So that leads to subfertility. So because of this, though the sperm is released frequently, the sperm is not able to search the egg. The egg and the sperm, they are not able to meet, and they are not able to form a baby. So that is the first most important complication, subfertility or delay in pregnancy. Second thing is irregular periods. As I told you, so much of hormones are getting secreted by all these small follicles, which are so much in number. So this doesn't signal the brain in a proper way. So there is signaling error to the brain. The brain again signals in a random way to the uterus. So the uterus inner layer of the uterine endometrium, it doesn't develop properly, and then again it is not shed out in a proper way. This doesn't happen in a monthly basis. So the patient has irregular periods. Only if a dominant follicle is selected every month, your periods can be regular. This is one of the major indications that whether you are ovulating or not. If you have regular periods, then most of the patients they will ovulate. Whether you have polycystic, whether you don't have polycystic, it doesn't matter. Whether you ovulate or not largely depends on your menstrual cycle. Patients with irregular menses, very rarely they ovulate. Most of the patients they ovulate only on a random basis if they are having irregular periods. So the next thing is, next important complication is recurrent pregnancy loss or recurrent miscarriages. All these things can also happen in polycystic. What happens here is, here the problem is with the oocyte quality. That is, when an egg is released randomly in a patient with polycystic, the egg is released under so many hormone stress. So much of hormone secretion is happening in a lady with polycystic ovaries. All the small eggs, they secrete some amount of estrogen, some amount of androgen. So when an egg is getting released in the midst of so much hormone confusion, naturally the oocyte quality comes down. That is the capacity of the egg to attract the sperm, capacity of the egg to turn into a baby, all these things comes down. So that is why the baby is not able to grow beyond a particular gestational age. So it just forms a baby. The baby grows inside the uterus, but because of the huge hormonal imbalance, the baby is not able to grow beyond a particular age. That is, probably by 7 or 8 weeks miscarriages can happen. So, also come conditions like biochemical pregnancy. That is, a pregnancy can form, but the baby will not be healthy enough to reach the uterus and get attached inside the uterus and grow as a baby. So, this condition is called as biochemical pregnancy. All these can be because of defective oocyte production and also defective hormonal signaling from the brain to the uterus, whereby there is defective implantation of the baby in the uterine endometrium, so that the proper blood supply to the baby is not happening because there is no proper signaling from the ovary nor the brain to the developing baby. So that is why the baby fails to grow beyond a particular gestational age. One more important thing in polycystic ovaries is the mouth of the uterus, that is the cervix, which is going to hold the baby, which is going to hold the uterus very tightly. It will open up only when the baby is ready to come out. That is, when the baby is 9 or 10 months gestational age, the mouth of the uterus slowly starts opening and the baby comes out. But for patients with polycystic ovaries, because of the hyperandrogenism, the mouth of the uterus is found to be a little weak. So there are chances for the mouth of the uterus to open up suddenly. குறை மாத பிரசவங்கள், குறை மாத குழந்தை பிறப்புகள் நடக்கிறதுக்கு நிறைய சான்சஸ் இருக்கு. ஏன்னா கர்ப்பப்பை வாய் ஸ்ட்ராங்கா இல்லாம வீக்கா இருக்கிறதுக்கு வாய்ப்புகள் இருக்கு. இந்த நீர்க்கட்டி பிரச்சனை இருக்கவங்களுக்கு அது ஏன்னா அதிகமான மேல் ஹார்மோன்ஸ் இருக்கிறதுனால அந்த கர்ப்பப்பை வாய் வீக் ஆகிறதுக்கு சான்சஸ் இருக்கு. ஸோ குறைமாத பிரசவங்கள் ஆகிறதுக்கும் நிறைய அபார்ஷன், அதாவது அந்த கரு கர்ப்பப்பையில ஒட்டியும் பிரெயின்ல இருந்து சரியா சிக்னல் வராம அந்த கரு ஒரு ஸ்டேஜுக்கு மேல வளராம போயிடும். அந்த கருவுக்கு ரத்த ஓட்டம் சரியா இல்லாம போகும். அந்த முட்டைப்பையில இருந்தும் சப்போர்ட் இருக்காது, பிரெயின்ல இருந்தும் சப்போர்ட் இருக்காது. ஸோ அந்த கருவுக்கு சப்போர்ட் இல்லாம இறந்து போகிறதுக்கு சான்சஸ் இருக்கு. ஸோ அபார்ஷன் ஆகிறதுக்கோ கரு ஒட்டாம போகிறதுக்கோ குறை மாசத்துல குழந்தை பிறக்கிறதுக்கோ வாய்ப்புகள் இருக்கு. இதுவும் ஒன் ஆஃப் த காம்ப்ளிகேஷன்ஸ் ஆஃப் பாலிசிஸ்டிக் ஓவரிஸ். அடுத்தது சைக்கலாஜிக்கல் இஷ்யூஸ். Psychological issues na, see, naturally the confidence of a woman comes down when she is not able to ovulate properly, when she is not getting her periods regularly. So that becomes a stress for a woman. She feels she's bloated up, she has mood swings, she feels she has all these acne and the abnormal hair development. All these things, they break the self confidence of a woman and they start experiencing depression. So this is also an important factor which has to be attended by the clinician. All patients, or not, most of the patients with polycystic ovaries, they have some sort of depressive complaints. The only thing they have to remember it is a treatable condition. They can definitely come out of this condition, but it needs some amount of determination and some amount of treatment also. So this is the only thing they need to hear. And there are so many treatment options which are available. So definitely with a little bit of counseling, determination and treatment, they can come out of this problem. So psychological issue is another important complication which should not be forgotten in a patient with polycystic ovaries. The next thing is, because of these abnormal hormone secretions, because of all these hormonal imbalances, what happens is, as I told you earlier, the follicle from the ovary, they secrete hormones which is responsible for the building up of the inner layer of the uterus, that is the endometrium. This acts like a bed for the baby. But then the follicle dies after some time, so the bed also dies and it comes down as periods. But sometimes, because of these hormonal imbalances, the bed is going on developing. There is increased amount of endometrial thickness, but there is no proper shutdown signal from the ovary for the endometrium to break and come out as periods. So this can lead to abnormally thickened endometrium. So the inner lining of the uterus can be going on accumulating the endometrium, but then because of the lack of the stop signal, it doesn't stop and it doesn't come out as a regular periods. So that is why they can start developing endometrial polyps, endometrial hyperplasias. All these conditions are because of the increased endometrial accumulation or increased endometrial thickness. நார்மலா மாசம் மாசம் உள்ள இருக்கிற கர்ப்பப்பைக்குள்ள இருக்க உள் ஜவ்வு வளர்றதுக்கான ஹார்மோனும் செக்ரீட் பண்ணணும். அதுவே கரைஞ்சு மாசம் மாசம் பீரியட்ஸா வெளியில வர்றதுக்கான ஹார்மோன்ஸும் முட்டைப்பை செக்ரீட் பண்ணணும். ஆனா இந்த நீர்க்கட்டி பிரச்சனை இருக்கிறவங்களுக்கு ஹார்மோன்ஸ் ஒரு இம்பேலன்ஸ்ல இருக்கிறதுனால உள்ள இருக்கிற ஜவ்வு சேர்ந்துகிட்டே இருக்கும். ஆனா அது கரைஞ்சு வெளியில வர்றதுக்கான சுரபி செக்ரீஷன் இருக்காது. அதனால உள்ள இருக்க அழுக்கு சேர்ந்து சேர்ந்து ஒரு சதை மாதிரி வளர ஆரம்பிச்சிடும். அதுதான் பாலிப் அப்படின்னு சொல்லுவோம். நம்மளுடைய நாக்கு மாதிரி கர்ப்பப்பைக்குள்ள ஒரு சதை வளர ஆரம்பிக்கும். அந்த சதையே ரொம்ப வருஷம் அப்படியே சேர்ந்து சேர்ந்து பெருசாகி பெருசாகி ஃபியூச்சர்ல ப்ரீ கேன்சரஸ் கண்டிஷன் அப்படின்னு இருக்கு. அதாவது கேன்சர் கிடையாது, அதுக்கு முந்தின ஸ்டேஜ் நிறைய இருக்கு. இதை விட்டோம்னா ஒரு 10-15 வருஷம் கழிச்சு கேன்சரா மாறலாம் அப்படிங்கிற கண்டிஷன் ப்ரீ கேன்சரஸ் கண்டிஷன் அப்படின்னு சொல்லுவோம். அதுதான் எண்டோமெட்ரியல் ஹைப்பர்பிளேசியா அப்படின்னு சொல்லுவோம். அந்த மாதிரி கண்டிஷனா மாறுறதுக்கு வாய்ப்புகள் இருக்கு. ஸோ இதெல்லாம் பிசிஓடைய காம்ப்ளிகேஷன்ஸ். நெக்ஸ்ட், இந்த பிசிஓனால மற்ற ஹார்மோன் பிரச்சனைகள், அதர் எண்டோக்ரைனாலஜிக்கல் டிசார்டர்ஸ் கேன் ஹேப்பன். கண்டிஷன்ஸ் லைக் டயபெட்டிஸ், hypothyroidism, hyperprolactinemia, insulin resistance, all these things can happen because endocrinology, அதாவது நம்ம உடம்புல சுரக்கிற சுரப்பிகள் எல்லாமே இன்டர்கனெக்டட் தான். முக்கியமா இருக்கிற சுரப்பிகள் பாத்தீங்கன்னா தைராய்டு, மூளையில சுரக்கிற ஹார்மோன், அதாவது இந்த ப்ரோலாக்டின் அப்படின்னு சொல்றது, பிளஸ் நமக்கு சுகரை கண்ட்ரோல்ல வைக்கிறதுக்கு இன்சுலின் ஹார்மோன், முட்டைப்பை, இது எல்லாமே they are all interconnected. So when there is hormonal imbalance in the ovary, நம்ம முட்டைப்பை சரியா சுரக்கல, இல்ல ஏதோ ஒண்ணு அதிகமா சுரக்குது அப்படின்னா இது எல்லாமே அஃபெக்ட் ஆகும். தைராய்டு அஃபெக்ட் ஆகும், ப்ரோலாக்டின் அதிகமாகும், இன்சுலின் சுரந்தாலும் அந்த இன்சுலின் வேலை செய்யாது. இன்சுலின் ரெசிஸ்டன்ஸ் அப்படின்னு சொல்லுவோம். ஏன்னா அந்த நீர்க்கட்டி பிரச்சனை இருக்கவங்களுக்கு மேல் ஹார்மோன் அதிகமாக அதிகமாக குண்டாகிறதுக்கான வாய்ப்புகள் வரும், தொப்பை போடும். சோ அதனால நம்ம உடம்புல சுரக்கிற இன்சுலின் பத்தாது. அதனால இன்சுலின் ரெசிஸ்டன்ஸ் வர 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 அவங்களுக்கு சுகர் வர்றதுக்கு சான்சஸ் இருக்கு, டயபெட்டிஸ் வர்றதுக்கு வாய்ப்புகள் இருக்கு. So all these endocrinological disorders can happen over a period of time if a woman is continuously having this polycystic disease. So these all can happen. So to summarize, the first thing is anovulation, because so many follicles are getting recruited by the brain and they come up to the surface, they secrete so much of hormones. All these hormones, the male part starts overtaking the female part because of the increased hormone secretion by all the small follicles. So because of that, brain signaling is becoming defective. The brain is not able to select one particular follicle, and that cannot ovulate, that cannot form a proper endometrial bed which will come out as your periods. So we have one of the questions from a viewer. So is hemorrhagic cyst means no ovulation? My follicle grows well, but after taking trigger it turns into hemorrhagic cyst. I have mild PCOS, 32 days regular cycles. Okay, so hemorrhagic cyst, she's asking whether hemorrhagic cyst means no ovulation. No, it doesn't mean like that. See, when a follicle breaks and when the oocyte comes out, what happens is the broken follicle can appear as hemorrhagic cyst in the ultrasound scan. How we can confirm this is you have to repeat the ultrasound scan after your periods. On the second day or third day of your periods, you have to repeat the ultrasound scan. If the hemorrhagic cyst disappears, that means you have ovulated. It is only the broken dominant follicle which is appearing as a hemorrhagic cyst in your ultrasound. It is not a proper hemorrhagic cyst. But if the cyst is persistent throughout the cycle, even after you getting your periods in the ultrasound, if there is presence of hemorrhagic cyst, then yes, there are chances for you to have that. And there are also chances for you to have anovulation. So with just one scan, we won't be able to tell whether you're having a hemorrhagic cyst or not. It depends on many factors. Size of the cyst, how long the cyst is present. If it disappears after you're getting your periods, then it is not an hemorrhagic cyst. It is only the ruptured follicle which is looking like that in the ultrasound. Mild PCOS, 32 days regular cycles, most of the patients they ovulate. They will not have problems with ovulation. So you don't have to worry much. Most probably your hemorrhagic cyst is only the ruptured dominant follicle, which is seen like that in the ultrasound. That we have to confirm it on the third day or fourth day of your periods. So after taking letrozole 2.5 milligram twice daily, I had 3 follicles growing. I have PCOS. Is it normal to have more than 1 follicle? Yes, it is definitely normal. So when you are doing controlled ovarian stimulation, that is, controlled ovarian stimulation is you are stimulating your ovaries to produce eggs, but then it is in a controlled manner. Usually we target about 2 to 3 eggs, not more than that. Patients with polycystic, since they have so many eggs coming up on the surface, they can easily form 2 or 3 eggs only with letrozole. So that is not a problem. You don't have to worry. You can allow all the 3 follicles to grow. You can allow all the 3 follicles to rupture. There are chances of twin pregnancies, about 10% chance. Very rarely, about 1 in 1,000 patients, they can have higher order pregnancy, but the incidence is extremely rare. So you can allow the 3 follicles to grow, allow the 3 follicles to rupture, and you can very well try for a pregnancy. It is not abnormal. So you can happy these things can happen by when you are doing ovarian stimulation. So I think we have answered both the questions. So I'll return back to the other discussion topics. Next is how can we treat PCOS? So what are all the treatment options which we have? First thing is lifestyle modifications. Lifestyle modifications, in what way do they help? First thing is when you reduce your weight, when you reduce your abdominal fat, naturally what happens is the male hormone secretion part comes down. Your female hormone overtakes the male hormone part. So it is not like you are not getting your periods, that is why you are putting on weight. When you do exercise, when you do a proper diet plan, naturally when you reduce your weight, the hormonal imbalance gets corrected and the brain signaling pathways also gets corrected, and the person starts getting her periods. So lifestyle modifications plays a crucial role in PCOS. When your abdominal obesity comes down, your female hormone part, it overtakes the male part, and your brain signaling starts to form a dominant follicle. So that is one thing. Next is for patients who are having only irregular periods. As I told you, the uterine bed is going on increasing in size, but there is no breakdown signal from the ovary for the endometrium to break down and come out as your periods. For such patients, you can give medicines from outside. Progesterone withdrawal can be taken. So most of the patients, they ask me this question: is it advisable to take this progesterone withdrawal frequently? Yes, progesterone withdrawal can be taken frequently, provided it all depends upon the quality of the progesterones which you are taking. Progesterones, if you are able to tolerate the progesterones, in that case, micronized progesterone tablets are available, which is similar to the progesterone which is being secreted in our own body. So these hormones, because of the defective breakdown signal from the ovary, the endometrium is not getting broken down and it is not coming out as your periods. So from outside, we are giving these breakdown signals to the uterus. So this helps in shedding down of the endometrium. Okay, so we have one more question. Is luteinized unruptured follicle common in PCOD patients? Yes. Luteinized unruptured follicle can happen in PCO patients because of the thick ovarian stroma. So as I told, the surface of the ovary is filled with so many follicles. So the surface of the ovary is so thick. So the dominant follicle has some difficulties in breaking and it has some difficulties in releasing the female oocyte. But the incidence is quite rare. And in ultrasound, it may appear as if the dominant follicle has not broken down properly, but exactly we have to confirm it by some hormone methods. And if this thing is happening in a persistent way, that is, if you feel that the ovulation is not happening every month, only in for such patients, we recommend the laparoscopic ovarian drilling. That is, by laparoscopy, we pass a needle and we break down the small follicles and we decrease the number of follicles coming to the surface. So this procedure can be done if you are having persistent luteinized unruptured follicle syndrome. Usually luteinized unruptured follicle is very rare. though it might appear in the ultrasound as if you have not ruptured the dominant follicle, but follicle rupture will happen, and oocyte, it is a microscopic structure, it will get released. But still, if you feel so, and if it is happening every month, then it is better to get a ovarian drilling done, so that will thin out the stroma, that will thin out the surface of the ovary, and that will help in the dominant follicle to break easily. So the answer to this is, just find out whether it is persistent, find out whether it happens every month. In that case, ovarian drilling can solve your problems. If it is not happening every month, then probably it is just this cycle where the signaling from the ovary to the brain is defective, so it has not ruptured. Then you can try once again. Try again for the next cycle. Then probably if your oocyte is healthy, then your follicle will definitely rupture. Okay, so next, what are all the treatment options we have available for this polycystic ovaries fertility concerned? So, for patients with infertility and for patients with the polycystic ovaries, so we have three treatment options. First is simple ovulation induction, that is controlled ovulation induction with oral medicines alone. Oral medicines alone can help in to break this anovulation cycle. So, what we are doing in this ovulation induction, as I told you, the follicles which is present on the surface of the ovary, they produce a signal to the brain, and the brain selects one particular follicle which is growing as a dominant follicle, which will break and release the oocyte. So here, by these medicines, we are going in two pathways. First thing is, we are either signaling the brain to select one dominant follicle, or we are directly giving the brain for hormone itself, which will directly go and select the dominant follicle. So these are the two methods we have. One is going via the brain, the other one is bypassing the brain and directly signaling the ovary to select one follicle. So these are the two treatment options which we have. If oral medicines are not enough, then we can substitute oral medicines with injections also, which will further help in increasing the quality of the egg. If both these treatment methods fail, then, as I told you earlier, ovarian drilling can be done. Laparoscopic ovarian drilling breaks down the thick surface, breaks down the excessive unwanted follicles which appear on the surface, and allows only the few healthy follicles which can maintain the proper signaling to the brain. So these are some of the treatment options which we have. So final one last thing is, how can we prevent polycystic ovaries? This is the most important question which most of the patients ask, especially in adolescent age. When a woman enters a reproductive age group, polycystic ovaries, if they feel they have a family history of irregular periods, family history of PCOS, it is better to start doing lifestyle modifications from as soon as the child enters the adolescent age group. Better to avoid junk food, better to avoid all the fast food items, regularly practice yoga and all the exercises which will reduce your abdominal fat. Though there is a genetic predisposition for the ovaries to become polycystic, all these lifestyle modifications can help in maintaining the hormonal balance and can help in ovulation definitely. Second thing is yearly screening. Once in every year, you do a screening for your thyroid hormones, for your sugar levels, and also for your hormonal imbalances. If at all you feel you have all these symptoms, you have irregular periods, you have all these acne, hirsutism, all these things, it is better to get a yearly check, even from a younger age group. It is not like only when you're planning for pregnancy you're supposed to check for all these. No. From the adolescent age group itself, you can do a yearly ultrasound scan, yearly hormonal checkup can be done so that it can be identified early. And the final thing is, if you are planning for pregnancy and if you feel you have any of these complaints, you start the treatment early so that you don't go into chronic ovulation. So that is the thing which is most dreaded in polycystic. That is, in spite of so many treatments available, in spite of so many methods available to produce a healthy egg, chronic ovulation, it happens in some patients where none of the treatment methods they work out. So we are forced to go to higher treatments like IVF. All right. The final question is, how lean, how much weight a PCOD patient is supposed to reduce? All right, you're supposed to maintain in your normal BMI, that is less than 24.5. So weight is not common for all the patients. So depending upon your height, you have to maintain your weight. Your BMI, that is the body mass index, it has to be less than 24.5. So that is the ideal recommended BMI. If you are maintaining in your proper BMI, then you can, of course, do all these yoga and meditation and other exercises which will try to maintain your hormonal balance. And the final thing about PCO is supplements, health supplements. What are all these health supplements? So many health supplements are there in the markets for PCOS. So the most important medicines which can help in reducing the hormonal imbalance and which can help in the brain signaling to develop one particular follicle is metformin, myoinositol, and to some extent vitamin D3. So these three things, they have some evidence in the research which has been done so far. So, what is metformin? Metformin is an insulin sensitizer. So, here, because of the obesity, whatever insulin is getting secreted in our body, it is not able to act. So, because of that, the male hormone part overtakes the female hormone part. Obesity continues. So, here, metformin, it helps in reducing your weight. It helps in reducing the androgen part of the hormone. It helps in increasing the female hormone part and thereby increasing the brain signaling. So that is why metformin is proved to play a role. The next thing is myoinositol, vitamin D3 and other preparations. All these preparations, they help in bringing back the hormonal balance correctly. That is the excessive hormone produced by all these small eggs. So it is reduced to some extent and the brain signaling is brought in a proper way to some extent. So these medicines are all proved to bring the hormonal imbalances to a normal way to some extent. Apart from this, all the other hormonal medications, all the other health supplements, they lack proper evidence in helping in PCO patients. So I would like to conclude my session with this. If you have any further questions regarding PCOS and the treatment options available, you can post in the comment section. Thank you.